Hello, everyone. I would like to thank Dr. Sabri for inviting me for this lecture. I really wish I am there in person, but I couldn't make it. The topic is really dear to my heart, and it's recently that I have acquired this interest in this topic, and it's the kidney, gut, brain, heart axis, a dreadful consequence of dysbiosis in chronic kidney disease. I'm Peter Sawaya. I'm the chief of nephrology here at the University of Kentucky. I've been at the University of Kentucky now for over 30 years. My disclosure, again, I'm an employee of University of Kentucky. I'm the deputy editor for clinical nephrology. And here I thank Dr. Sabri again for being a reviewer for us for many, many years. I am not an expert in nutrition. This is not, something I'm learning about and I'm very interested in. The objective of my talk is differentiate between microbiome and microbiota, recognize the axis of evil, I call it, kidney, gut, brain, and heart, list the factors that promote dysbiosis in chronic kidney disease, differentiate between probiotic, parabiotic, postbiotic, prebiotic, symbiotic, and bioactive compounds, and finally describe this new term, microbiome therapeutics. We have right now two residents working on two patients we have in our practice that have survived hemodialysis for over 30 years. And I'm really very interested to know their lifelong history. And I can assure you, I don't know the results yet. The residents are working on it. What they are going to have in common is their diet and how active and exercise they do, what kind of work they have. That's what making them live so long on dialysis. I take it. They are not diabetic. Neither one of them is diabetic. Stay tuned. It will be published. Now, it started in Egypt. What started in Egypt is making bread. And you know, this is the main source of nutrition and calorie and carbohydrate for thousands of years. So what did the Egyptian discover or describe is fermentation, which is the chemical breakdown of a substance by bacteria, yeast, or other microorganisms. And that's exactly what's happening in the intestines of our patient with chronic kidney disease, with dreadful, as I said, consequences. So let's get the terminology straight. Microbiota versus microbiome. Microbiota is the actual bacteria that are living in an environment, which in this case, our intestine or the patient's intestine. And look at this number. I mean, trillions. There are trillions of bacteria living in the intestine. Now, microbiome is the footprint, the genetic footprint of those bacteria. They have genomes, and it's easier to identify when you do genetic testing and they come up with a big panel, and than culturing individual bacteria and identify it. So microbiome is the genomes of those bacteria, and microbiota is the actual bacteria. Now, the microbiota of the intestines, we have two types of bacteria. The good bacteria, we call them, or saccharolytic. And the saccharolytic, they live on carbohydrate, and they produce beneficial products like SCAFA, or the short-chain fatty acids. These are acetate, propionate, butyrate. They promote cell growth. They promote integrity of the intestines, and they compete with the bad bacteria by shutting them down. Now, the bad bacteria are the opposite, are the proteolytic bacteria. These are the putrefied protein. They putrefy protein. They produce, instead of beneficial product, they produce harmful molecules like ammonia, amines, thiols, phenols, and indoles. And all these, by the way, are uremic toxins, and I will show you. So what dysbiosis in chronic kidney disease means, A, we have decrease in the amount of the beneficial bacteria, which, like, for example, lactobacilli or bifidobacterium, to name few, that they produce beneficial products. On the other hand, we have increase in the bad bacteria that produces urease and tryptophanase and metabolite bunch of a protein to molecules that are harmful, the indole, phenol, and amines that are actually uremic toxin. And here is a huge list of bacteria that can do that. So why chronic kidney disease specifically leads to dysbiosis? Why not everybody, other diseases? Urea itself promotes the growth of proteolytic bacteria. And urea is present everywhere in our patient. Not only in the blood is increased. It's in the saliva increased. It is in the intestinal secretion, it is increased. Of course, it is in the skin and in the sweat gland and give you the uremic frost. Urea is everywhere. Low fiber diet. We always don't put potassium. Worry about the potassium. So they are on a low potassium diet, and then often they are on low fiber diet. High protein intake for fear of being malnourished. Polypharmacy, big issue in our patient. Tons of phosphate binders and antibiotics. High intestinal pH from converting again urea to ammonium hydroxide. So pH is high. Constipation is a very common symptoms in our dialysis patient and CKD patient, and often we try to ignore it. And there are non-CKD related factors, but frequently present in CKD patients, like obesity, sedentary lifestyle, diabetes, alcohol, and smoking. All those, they promote dysbiosis. Now, uremic toxin, I don't need to define it for you. It's a molecule that accumulate in somebody with decreased kidney function, but they have to be detrimental. We can accumulate all kinds of stuff, but they are not harmful. But these are harmful molecules. They can be small molecular weight, which dialysis take care of. They can be large or middle molecule, which is hard to get them away from with dialysis. But they can be often small molecule, but protein bound. That means they cannot be taken care of with dialysis. And that is exactly what's happening in dysbiosis. If you look at all the uremic toxins that are listed here, and you can see the phenols, indoles, and amines, they're all rather small molecular weight, 100, 250, 94. So they are really small. Yet they are all protein bound and hard to get rid of on dialysis. So we have what I call a triple whammy effect. 3 hits. First, we have increased intestinal production, dysbiosis. Second, we have increased permeability, and I'll talk about it in a second. This production in the intestine is seeping back to the blood. And third, of course, we have chronic kidney disease and decreased clearance of those molecules. Not only the kidney is not working, but dialysis even doesn't take care of them because they are protein bound. Triple whammy effect. Why there is increased intestinal permeability specific in CKD? First, again, uremic plasma decreases the tight junction protein that keeps the mucosal cells tight together. So they are decreased in there. Not only it seeps back those small molecules of phenol and indoles and amine, but even large bacterial dead tissue, bacterial product, element of bacteria can go back. And of course, endotoxins can go back to the blood. Edema in the mucosa. I mean, we have edema all the time in our patients, in their legs. So how is their intestines? How is this edema in the intestine making it, what's the integrity of that intestine when you have edema in it? And finally, again, urea is converted to ammonium hydroxide. Ammonium hydroxide is a product we put in detergents and in places where we want to clean our bathroom. That's when we want to scrub the bathroom because it's so erosive and cleans. That is what our intestines, the patient's intestines is exposed to. Now, there are many examples of how bad are those phenol, indole, and amines, and I don't want to go there. I don't have enough time for it, but this is just one example of the amine, phenylacetylglutamine. The higher the level, as you can see in the third, the upper tertile, the worse is their survival of CKD patient. I think these were on dialysis. So, and there's many, Cresol, there are many studies in that regard. These are not benign molecules. That's the point I'm trying to make. So here's the kidney, gut, brain, heart axis. It all starts with the chronic kidney disease. We have decreased kidney function. You have dysbiosis, as I described, that is increase in proteolytic bacteria and decrease in saccharolytic bacteria, the good bacteria. That increase in proteolytic bacteria will lead to increase in the production of indoles, phenols, and amines, and all those poisonous small molecules that are highly protein bound. Now, these, again, the intestine is leaky. They seep back to the blood, and of course, they hit your brain. And when they get the brain, they again produce other stuff. Neopterin here, they're mentioning, and chenorenins, which is a tryptophan metabolite. Remember tryptophan? We take it to help us sleep. They tell you if you eat turkey, you get sleepy after that. So here again, our patient, look at our patients. Look at our CKD and dialysis patients. They look like they have severe hypothyroidism. They look, they almost half of them asleep during dialysis. They're sluggish. They have all that, and then alteration in serotonin turnover. They're depressed, and they have cognitive dysfunction. This is not news to any one of us. On the other hand, you get to the blood vessels and you increase inflammation in the blood vessels. You increase fibrosis in the myocardium, all the factors that promote these processes and then lead to increased cardiovascular risks and death. That's the heart axis. So we are living, our patients, CKD patients, are living in a vicious cycle. We have a chronic kidney disease that lead to dysbiosis and increased permeability of the intestine that will lead to seeping back uremic toxins to the blood. These uremic toxins promote inflammation, atherosclerosis, dysregulation of the immune system by increasing T helper, reducing T regulatory cells. There are quite nice recent study about that, and promote fibrosis. Fibrosis not only in the heart, but also in the kidney itself, which would lead to further decrease in GFR and further worsening of chronic kidney disease and vice versa. And you keep going into this cycle. How can we break? How can we break this cycle, this vicious cycle? I think diet has a lot to do with it. You may disagree, but I'm really, we need, well, I'll talk about probiotics, paraprobiotics or postbiotics, and I define them to you, question mark, because again, they haven't been proven. Prebiotics, symbiotics, bioactive compound, and the new term microbiome therapeutics. Let's go back to the father of renal physiology, of modern renal physiology, Homer Smith, 1953. It is no exaggeration to say that the composition of the body fluids is determined not by what the mouth takes in, but by what the kidneys keep. Absolutely true. Absolutely true. But what would happen if you don't have kidneys? Then I will tell you the opposite is as true as this one is. That is, if I don't have kidneys, anything in my blood, anything in my tissue compartments is determined by what I eat. So here's the mighty Mediterranean diet. And you are from Mansoura, guys, just go up the Nile and you are a few miles from the Mediterranean. Alexandria, the beautiful Alexandria is in the Mediterranean. What's the difference between the Western diet and the Mediterranean diet? Here's the Western diet. Fries, hamburger, big steaks, 16-ounce steaks, all these. What do they do? Not only that, also all the preservative that are in canned food and things to keep the life shelf of those food longer. We have increased proteolytic bacteria and decrease in saccharolytic bacteria, and then we have promote dysbiosis, the diet itself, and that will lead, of course, to the bad bacteria, and then cresol and indole and amine and what have you. On the other hand, Mediterranean diet, olive oil, the king. Olive oil there comes from the olive trees. What's the name of olive trees? The green gold. You know, petroleum is the black gold, but the olive trees are the green gold, and they are gold not for nothing. And that term comes from 1,000 years. I don't know how many years ago, but olive oil, fruit, vegetables, these things that promote saccharolytic bacteria, decrease proteolytic bacteria, and that had lead to SCAPA, the short-chain fatty acids, that promote health of the intestine, of the mucosa of the intestine, produce anti-inflammatory, anti-oxidative molecules. So, and that will reverse dysbiosis. What other things that you can do without, which Mediterranean diet has a lot of these. Again, you want to get for protein, you are worried about protein in your patients, give them vegetable protein more than animal protein. Soybean, beans, chickpeas, peas, lentils. Another philosophy that we need to change. We all tell the patient, be on low potassium diet, be on low lipid diet, be on low phosphate diet, blah, 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 blah. And what's the end results? What is the totality of that patient's diet? What is he eating at the end of the day? That's what we need to know. We look at the totality of the diet and we want to see it rich in fruits, vegetables, fish, whole grain, fiber, reduce in red meat, sodium, and refined sugar. Nuts, good for you, olive oil, again, the gold liquid. I propose this one. I'd like to see a scale of that nature in every dialysis patient, in every CKD clinic that I will do any dietary interview with the patients. Where, you know, we know what they are eating the whole day. How much is it related to olive oil, vegetable, fruits, and these good stuff? And how much is related to French fries and meat and this stuff? And put a scale for me, percentage-wise. And I want them to see in the green area. If they are in the red area, we need to talk. We need to do something to bring them to the green area. Now, probiotics are the actual bacteria, the good bacteria that we're talking about. But think about it. Why the good bacteria already died in the intestine of our patient? Because the milieu is not favorable for their growth. So you can't give them a pill that has a bunch of those bacteria and then expect us miraculously to survive there. In fact, they will die and promote inflammation. And then they are not recommended in CKD alone. You got to change the milieu in the intestine before you give it to them. Parabiotic or postbiotic, that means you give them the activated, you know, the product, the good product that comes from the saccharolytic bacteria. And those may be beneficial. We don't have many studies about them. And perhaps it will be something that we can use in the future. Prebiotic, these are my favorite. These are natural things. These are natural things that we eat, that we find in nature, that promote the growth of the good bacteria. Fibers, oligo, polysaccharides, resistant starches, fruit, cereal, vegetables, honey. Give that to the patient, and that will promote, again, you have probably to make other changes also to make sure they don't, those bacteria dies in this milieu. And encourage, so it is recommended to encourage patients to increase intake of prebiotic, particularly fruit, vegetable, cereal, and honey. Symbiotics, and this is the field, this is part of the microbiome therapeutics, is where we do multiple maneuvers. At one hand, we change the milieu, and the other hand, we'll give you the bacteria, and hopefully that will lead to some improvement. So pro and prebiotics at the same time. Very limited studies, so nothing to recommend yet, but I can see in the future coming up. And there is some preliminary data, improve GI symptoms, increase the count of a good bacteria. So at least we know they are surviving with this maneuver, decrease the precrystal and decrease BF. Bioactive compound, the most studied one is polyphenols. And we all know about the grapes and red wines. And perhaps the survival in Tassin, France, they always, brag about their survival on dialysis. Perhaps it related somewhat to polyphenols and not the fact that they dialyze them for 6 hours. It's a pomegranate, garlic, green tea, chocolate, turmeric, and cranberry. All these have polyphenol, which is a very potent antioxidant and anti-inflammatory molecule. Also, it is metabolite to urolithin A, which increase the tight junction protein and improve the integrity of the intestine. Not much study in dialysis patient or CKD patient, but no harm. Now, microbiome therapeutics. Now, there is just a recent, a very short editorial at CJS, and just last month I came across it, that defined this microbiome therapeutic, and it has 4 legs. I mean, 4 things that we do: specific strain or engineered microorganism, not just pro-like, that you get over the counter, those probiotic bunch of bacteria on, specific bacteria that has a specific role that will inhibit a specific conversion of and production of those uremic toxins. Stool transplant may do that because, again, you have a normal environment that you're inducing to the patient. Elimination of deleterious microbia, so kill the bad one by bacteriocins and bacteriophages. Prebiotic, as I told you, I mean, the material that makes the good bacteria grow. And postbiotic, the product of the good bacteria. Not give them the bacteria themselves, but give them what is good about them and try to give them. A combination of these things that may lead to a healthy environment. And here's the microbiome therapeutic. They give you an example what they do, like prebiotic and probiotic. You see, you can do one without the other. For example, it will lead to methanogenic archaea, the bacteria that goes. So when TMA, which is an amine, is being produced, those bacteria start eating it up before they go to your blood. For example, bacteria without urease, so specific bacteria that doesn't have urease, so you don't convert urea to ammonia. And a sulfur-rich diet that will block the tryptophanase, tryptophanase, so you will have less indole, you will have less cresol. And finally, as it does the prebiotic complex polysaccharide, will promote SCAFA or short-chain fatty acid, which again restore the pro-inflammatory process that is happening, which is again increased T helper cell, decreased T regulator cell, reverse that and improve in cardiovascular outcome. This is the future. This is coming, and I think we need to pay attention to it. We pay attention to the diet of our patients. So to conclude, dysbiosis is common and serious problem in chronic kidney disease. It contributes to quality of life, progression of chronic kidney disease itself, and survival. Look for it. Ask the patient about their GI symptoms. Make sure they're having bowel movement and not constipated. And if there is a problem, act. Try to change their diet. Do what you can do to improve the milieu of their intestine. Modify the diet, eliminate precipitating factor, use prebiotic and bioactive compound in dietary form, no drugs, no pills. Monitor labs more often. If you're worried about potassium, check it more often and do something. Reassess frequently. How are the symptoms? Don't just do one maneuver and then sit back and don't follow. And then again, microbiome therapeutic is in the future. So I thank you for your attention. I will be, I think, logging on the conference if anyone has any questions. Again, sorry I couldn't be with you.